tonight we're going to be talking all about a brand new product, which is something we love doing here. So we're introducing the Optovue Solix by Visionix, and this is the first FullRange SD-OCT. And I can't tell you all the details about the product because I'm certainly no expert, but fortunately we have the expert here tonight, Dr. Julie Rodman, who's a professor at Nova Southeastern, who I think just about everyone's familiar with. She is the expert on OCT. It's really great to have her here today to talk to us all about this new device. She has extensive experience with it already, and she can go over some of its features and really catch you up to speed on what it's all about. So that's enough for me. Julie, why don't you take it away?
Okay, thank you so much, Adam. As Adam said, this is Dr. Julie Rodman. For those of you that don't know me, I am a professor at Nova Southeastern in Fort Lauderdale, Florida, and chief of the Broward Eye Care Institute in downtown Fort Lauderdale. And I have been fortunate to have the Solix in the clinic for the last couple of months because I was doing a very cool study on it. So I have had an opportunity to play with it. And I will tell you that I have not been so excited about using a new OCT in a very long time. This machine is rocking it. That's all I can say. So let me get started here. So as Adam alluded to, I'm going to go through some of the amazing things that Solix is going to bring to us, starting with FullRange Anterior Segment, and I'm going to show you images of everything that I'm talking about. So what does FullRange Anterior Segment mean? Essentially, it's going to give us a panoramic view of the anterior segment of the eye from the front surface of the cornea to the posterior surface of the lens. So we don't have to go through multiple images to essentially see the entire front surface of the eye. And I do want to say that when I first got this machine, everyone that knows me knows I love retina, but when I first got this machine, this feature took my breath away. So my husband is on the side. When I have this machine in front of me, this is what captures my attention. But this scan is incredible, and you'll see it in just a minute. We also are going to still have the ability to look at ocular surface disease and angle assessment. So that is obviously going to carry over from the Avanti and all other Optovue units. FullRange Retina, the scans are going to be bigger. They're going to have better resolution, better definition. The glaucoma protocol is one of the biggest modifications in this new Solix device. There is a new scan pattern that's going to make the repeatability and reproducibility much better, allowing us to have faster detection, and better care of our patients. The AngioAnalytics we all know and love. I still think that Optovue owns the market in this area. We were the first OCTA to have this AngioAnalytics FDA approved. We have quantitative data that has been FDA approved. So we rock in this area. We still are the only ones to have that. We have excellent projection, artifact removal that, again, in my opinion, is unparalleled. The AngioWellness platform put Optovue on the map. This is really the platform or the protocol that allows us to early detect disease. If you can't find disease, you can't treat disease. So let's jump into some of these amazing images. So here, pardon me, let me go back. Here is that incredible anterior segment, anterior chamber image that I was talking about. What you'll notice here is this is what we call a full panoramic view of the front part of the eye, from anterior cornea to posterior surface of the lens. Everything is on one image. And like I said before, every time I see this, these images blow me away. One of the really cool things about this is that we're not going to have to take separate angle images, and I'm going to go into more detail in just a minute, because everything is essentially on this one image. You can even view a cataract through the lens because the definition and the resolution is so outstanding. This was a picture of a patient that I took. You will notice that this Solix also has the ability to take a picture. So on the left side of the screen, you'll see this really pretty picture of an anterior chamber implant with an LPI. And what's really neat is that you can actually image the anterior chamber right along, or you can view the anterior chamber right alongside the picture. So you'll notice on my anterior chamber scan here that you can see this anterior chamber lens situated right here. So I think this is super, super cool, because if you have a patient that has an anterior segment pathology like a pterygium or a pinguecula or a conjunctival intraepithelial neoplasm that you want to look at on OCT, you can actually look at the image simultaneously with the OCT. So this is a new feature of the Solix, and it's also pretty incredible. This is just a summary of some of the great anterior segment features of this technology. So we are carrying over the epithelial thickness map testing, which we use in dry eye assessment and also assessment of other anterior segment abnormalities. We can measure tear meniscus by looking at the corneal line scan. We can do an en-face map of the corneal tear film interface to look for dry eye or any other surface abnormalities. And this is super cool. This is new. This technology has an infrared image that allows us to look at the meibomian gland patency. So you can see here in these images, the little kind of gray lines here are meibomian glands that perhaps have atrophied. So you can check patients over time and check for the patency of their meibomian glands. So this is a new feature and a fantastic, exciting feature for those of you that are treating dry eye. These are some more anterior segment features. We're all familiar and love the Pachymetry assessment that you can see here on the left-hand side of the screen. This is the good old-fashioned way that we used to measure on the Avanti. We used to measure angles, and I will tell you that I get a lot of questions from colleagues on how to properly assess angles using OCT, and the Solix takes away so much of the questions, or so many of the questions that I get asked, because you don't have to worry about having the patient look in a certain direction or move their eye a certain way to reduce parallax or to reduce any aberration. With this new technology, you can image angles straight on. You can put your calipers right in the little crevice here, and you will have your anterior segment measurement, or I'm sorry, your angle measurement. So this is a huge, huge benefit of this machine, because there are so many errors in angle assessment when you don't know how to do it properly. So using the Solix and using this full range AC feature really takes the guesswork out of it. The next amazing feature, just kind of going through our list, is what we call FullRange Retina. So one of the things that this technology is bringing to us is a bigger scan. What you'll notice here is that this scan is a 6x16. So that is a huge scan. So in this patient here, this happens to be a high myope. We all know that imaging high myopes on OCT is often extremely difficult, because the images give you a very convex shape and you can't always get it on one scan. But using the FullRange Retina and using this new larger scan, wider, deeper scan, is going to allow us to get the entire image on one scan. And just to kind of put this into perspective, if you look at our competition, this is what they're imaging. They're imaging a 2 millimeter on average window. Look how much of the retina you'd be missing essentially if you didn't have this taller scan. So this is a huge asset, because especially in high myopes, you can get a lot of pathology that's not happening directly in the foveal area. So if you had a macular schisis, or you had some type of pathology that was happening outside of this 2 millimeter width, you essentially would have to go through multiple raster scans to capture the entirety of the lesion. These images, second to the FullRange AC, are ridiculously incredible for being my favorite. So the Solix gives us many options, just like the Avanti did. There's a 3x3 that's not imaged on this particular slide. There's a 6.4 by 6.4, 9x9, and now a 12x12. And if that's not enough for you, can do a montage as well. But look at the resolution. So we're often told, you know, when I've been talking about OCTA for years now, and one of the biggest downsides to OCTA is that, or used to be that, when you're getting farther out and you're trying to get more, you know, bang for your buck, you're going to lose resolution. Well, that no longer is the case. These images have a ridiculous amount of clarity. The resolution, its high definition is just, you can see, I mean, I don't need to tell you that, pardon me, that the resolution of these scans is really tremendous. And this is a 12 by 12. This is a big scan. So we can find pathology now and not have to worry, is that an artifact or not, because we're going to carry the resolution over that we had on the Avanti. It's going to be even better now because you can get farther out. So this is another huge change that Solix is bringing. And I am very excited about it because it's actually taking a lot of the guesswork out of OCT interpretation. So on the Avanti, we used to have this color metric on the left-hand side. It was a rainbow. We had red, yellow, green, light blue, dark blue. And essentially when a practitioner, including myself, saw red, I would say, uh-oh, that patient is falling outside of the reference database. They're abnormal. And what began to happen is that I was picking up on a lot of, quote, red disease. Essentially what that means is that I was identifying patients that were abnormal when maybe they really weren't abnormal. Okay? Maybe they didn't fall within the selected reference database, but that doesn't necessarily mean the patient's abnormal. So the new metrics, or the enhanced reference database metrics, have a new color scale, which you can see here. And essentially what this is going to do for us is it's going to take away a lot of that red disease. So if a patient falls somewhere between the 99, 95th percentile in here, and we're not sure, well, do they really belong in the red? Do they really belong in the yellow? Where do they fall? They're going to get this orange kind of diagonal line. And that tells us, hold on, doctor, that doesn't necessarily mean my patient's abnormal. It means we're going to take another look at them. We're going to think about it. Maybe they're going to go red, or maybe they're going to stay in that orange, or maybe they might even be yellow, but they're not necessarily abnormal. And this, again, is going to help us to not use or not devote the word red to so many patients that might not necessarily be abnormal. So you can see on this presentation here that the RNFL thickness map is demonstrating this new RDB, and you can see these orange kind of hash marks here showing us that those areas, yes, they're on the borderline. They're falling somewhere in that 95th to 99th percentile, but they might not necessarily be red. And on the same idea, we have it with the blues. So if a patient isn't necessarily in that really low 1%, but they're somewhere down there, they're going to have that hatch mark in the lighter blue, which you'll see on the retinal thickness map. So these color scales are going to transfer over not only to our RNFL, but also to our retina scans. And as you can see here, this is in a quartile or quantile method, the same idea. We're going to use the same RDB colors to show the statistical significance of various parameters using this new color scale. This is an example of what a bilateral AngioView retina report will look like. There's a lot of data on here. So what we should do as practitioners to make it easier is to start off on the two outside columns. The first thing you're going to notice is that, yes, not only does the Solix have an anterior segment camera capability, it has a posterior segment camera capability. So what you're noticing first is that we took two retinal photos, obviously right eye, left eye. Directly underneath the color photo, you can see the B scan. The B scan can be displayed with or without flow overlay. This particular one has the flow overlay. Directly beneath that, you can see the GCC thickness map on a micron scale, and you can see the retinal thickness map using the new and improved RDB database that I just discussed. In the center, you can see the AngioAnalytics platform for the right eye, the left eye, with each of the pre-cut slabs that Optovue is known for: superficial, deep, outer retina, and choriocapillaris. And on the bottom of the printout, you're going to see all of the parameters that apply to our analytic platform. FAZ that we know and love, our retinal thickness map, superficial vessel density, deep vessel density, all in a quantitative, numerical way that's easy to follow. So even though at first glance it might seem like a lot of data, it's actually very easy to interpret if you kind of start on the outside and move your way in. And it also allows you to look at an inter-eye relationship. How does one eye compare to the other, all on one page? So I said before that the glaucoma protocol has changed tremendously. and it has changed tremendously for the better. So what I'd like to do here, you know, when my friends at Optovue first gave me this slide, I said, oh man, there's no way that I'm going to be able to discuss this. But believe it or not, I actually became a little bit of a scientist when I tried to learn what this technology is doing. So on the top part here is our old glaucoma stuff. And on the bottom, I'm sorry, vice versa, retina, glaucoma. So let's start off on this side first. This is what the old Avanti used to work on. What this is it used a grid style map. It was a 6x6 grid style map with 250 and 500 micron spacing to look at abnormalities. So essentially, if a patient had an abnormality that fell somewhere within one of these grids, you would find it. But what if the patient shifted fixation? What if the ETDRS shifted? You would lose that defect either because the micron spacing was too large or because the map was not big enough to capture it. So what the Solix is doing differently is it's using a cube style grid, or not a grid, it's a cube style, it's a retina cube. It's a 6.4 by 6.4, so it's bigger, and it's 12.5 micron spacing. So it's a tremendous advantage over what the Avanti used to do. So if the patient shifts fixation and you're worried, oh my God, am I going to miss the lesion? There's a very small probability now that you're going to miss the lesion with this new technology. On the bottom, you'll see that our RNFL for glaucoma used to be based on a radial line pattern because it was super, super fast to get. For those of you that are familiar with this, with the Avanti, super fast to get a radial line RNFL scan. But again, lots of space between the concentric rings. The new Solix is going to again use a cube, a 6 times 6, 512 by 512, giving us 11.7 micron spacing. So you're going to get so much more information in between the lines than you did with the concentric rings. And here is a really pretty example of what I'm talking about. On the left-hand side is an example of what we were using on the Avanti, these radial scans, okay? Very fast, very efficient, but more prone to missing things than the new Solix. Check it out. I love this. So you can see how close together these lines are, allowing us to take a much more specific look, or more precise look at abnormalities than on the old radial pattern. So in turn, what is this going to do for us? We've improved the scan pattern. Okay, we know that we have much tighter microns. We're getting more information. So what does this do for the doctor? Well, essentially, it's going to give us better reproducibility and repeatability. Well, what does that mean? It means that if you were to look at the Avanti, just for argument's sake, let's say we were looking at the superior RNFL on the Avanti. The repeatability is 2.2 microns. On the Solix, for the same area, the repeatability is 0.7. Well, what does that mean, Dr. Rodman? I don't understand. It basically means that if you have a 1 micron change that you're trying to pick up on, it's going to take you almost double the amount of time to pick up on that abnormality than it would if you had the Solix with a 0.7 micron change or repeatability factor. Okay, so it's going to take us a lot less time to diagnose someone with glaucoma. And as we all know, glaucoma is a disease of progression, and we're looking for change over time. So this is very important. And something else to keep in mind is that Optovue is, there might be one I don't know about, but Optovue is, in what I know, the only one that bases their GCC on 3 layers: the nerve fiber layer, the ganglion cell layer, and the IPL. The IPL is often missed, and the IPL is super important because it does carry information on the axons which go into the optic nerve head. So that's a super important thing that may be missing from the other companies. So here's a map that shows you exactly what I was talking about. On the top would be, let's say, a schematic of the Avanti. On the bottom is the Solix. You can see that it would take each of these little yellow dots is a visit. It would take all of these visits at a little more than 1.5 years to find that the patient actually is progressing with a 2.2 micron reproducibility, versus on the Solix, you can see how much less time, 3/4 of a year, using that 0.7 micron change. So it's a much tighter amount of time, gives us better information because of the new scan pattern, and allows us to make a diagnosis in a faster amount of time. This is what the glaucoma printout looks like. So before I showed you the AngioView Retina printout, this is what the glaucoma printout looks like. And again, a lot of information, very easy to interpret. So what you'll notice is we start off again on the 2 outside columns. We have an optic nerve head photo here. Okay, so before we had retinal photos, here we have optic nerve head photos. Right next to the optic nerve head photo, you can see the RDB. What this is telling us is, where does this scan differ from the reference database? So those colors are showing us where there's areas of abnormality. If you go down, you can see that there's a GCC thickness map on a micron scale. And what's super cool about this printout is that I started off telling you that we have this RDB map up here. Right below it, we have our RNFL thickness map using the new RDB or reference database. And then below that, we have our AngioAnalytics platform with this radial peripapillary capillary density map. So you essentially have 1, 2, 3 ways, all kind of right in line for you to assess an abnormality. You don't have to go through scans. You don't have to flip between images. This is showing you 3 different representations of nerve fiber layer thinning in a potential glaucoma patient. So if you don't necessarily love angio and you're not familiar with it, you can use your RNFL thickness map. You can look at the reference database colors up here. So there's a lot of different ways. Then you can look at things, which I'm showing over here, on a quantitative map. So if you like numbers, you can look at things either in a hemispheric or quadrant analysis. And on the bottom, we have our good old-fashioned B-scan. And the B-scan is actually movable. So you can take your mouse and you can move through the scan. You don't have to go to your 3D baseline map. In the center here, we have all of our metrics. These are the metrics that we all know and love with Optovue. Very easy to understand: our RNFL analysis, our optic nerve head analysis, GCC analysis. And then on the bottom, we have our angio, our radial peripapillary capillary density metric or map. So, and our T-SNP maps are still there. So everything is in one very, I think, easy to interpret way. And again, the ability to have all this information on one page allows us to look at inner eye symmetry or asymmetry, depending on what the condition is. We also have amazing post-processing alignment, and the purpose of this is so that we can look for change over time. So if the patient moves, or if the scan moves, or something goes awry, there's a lot of room for error because of this excellent post-processing alignment technology. This is an example of what the change analysis or trend analysis would look like. This is new and improved. I love it. The top, you can see the RNFL based on that RDB map that I talked about before. Underneath it, you can see the GCC map on a thickness scale. Here's my T-SNP maps with all of our events that we're used to seeing on the Avanti. One of the biggest changes down here is the representation of change. So this is super easy to understand. You can look at any area of the RNFL, and all you have to ask yourself is this straight or is it going down? If it's a plateau and it's straight, the patient's doing well. If it's going down, if it's trending down, the patient is obviously progressing. So this gives us much more specific information than we used to see on the trend analysis. We used to just have one map. Now we can specifically look at areas. We can look at hemispheric analysis. This gives us 6 representations versus 1. And over here, you can still see from first to last visit what's happening and the differences between the eyes. And we all know and love the angio. That is still there. We still have all of these metrics available. We have flow area measurements for things like choroidal neovascular membranes. We have no flow measurements for things like diabetes or vascular occlusive disease. We have fovule vascular zone measurements for diabetes, vein occlusions, any ischemic condition. Retinal vessel density, warm colors, good perfusion, dark colors, less perfusion. And then our ability to look at the radial peripapillary capillaries, which is extremely useful in our glaucoma patients. And we all know and love the wellness platform. This is, again, what put Optovue on the map. You can't diagnose disease if you can't find disease. So we want to get into the habit of running a wellness map or wellness scan on patients. And when we find disease, bring them back and use the amazing capabilities or the more advanced scans that the machine has. Just going to run through a couple of examples, which I think will kind of summarize my presentation today. This is an example of wellness. So this is a 45-year-old African-American female. She's got a decent A1C of 7. We want it in the real world or realistically to be below 6. She's got diabetes for 10 years with excellent blood sugar control. And really what I want to emphasize here is that you look at her fundus image, she may have 1 or 2 MAs. You look at her OCT, she looks amazing. So, you know, before the advent of OCT, this is a patient that we would say, please come back in a year. I'm really proud, you're doing amazingly well. Well, let's say you did run a wellness scan on her. You get the wellness scan, you have your B scans on top, you have your retinal thickness maps, you have your ganglion cell complex, you have RDB, you have the addition now of AngioAnalytics on the bottom, and you ask yourself, what do I do with this? What does this mean? Well, when you get really good at interpreting angio, you're going to appreciate that there actually is something not so good with this vessel density map. The RDB map is falling a little bit outside of our reference database. So here I show you our patient on the bottom for a diabetic patient versus the control. So you can learn to appreciate what this wellness scan is telling us is maybe this patient isn't doing quite as well as we thought she was. How would I manage her differently? I probably would communicate with the primary care physician and bring her back sooner than I would have without it. So early detection, early diagnosis equals better care. Some retinal case examples. Diabetic retinopathy, we know in a normal patient without, I shouldn't say normal, but a patient without diabetic retinopathy, we have a very well perfused, superficial and deep capillary plexus with a very nice circular foveolae vascular zone. In our diabetic patients, we know that we can look for less perfusion throughout the superficial and deep plexi. We can see enlargement of the foveolae vascular zone. We can see microaneurysm formation, and we can see bunches of areas of blackness, which are areas of non-perfusion. So being able to identify these microvascular abnormalities early on is really crucial in taking the best care of the patient. Here's another, this is going back to our patient that had maybe 1 or 2 MAs with a normal OCT. We did the wellness scan and we identified that she had some abnormalities on her vessel density map. So we brought her back and we ran the Solix for the best, get the best information that we can. And we come up with this. And essentially, this is what I was telling you, is that even though fundoscopically on B scan, structurally, we think she looks okay, she's got a lot of stuff happening behind the scenes that potentially could lead to this in a year. So the idea is we don't want this to happen. We want to arrest this at the stage where she is over here. Okay, we don't want it to go on and develop massive areas of poor perfusion. We can't even see the foveolae vascular zone. So this is what we want to stop. Here's another 50-year-old diabetic female who's been a diabetic for 10 years with an A1C of 5.9. Her vision's 20/20 in both eyes. And I look at the pictures and I'm like, man, she looks pretty good. But on really close inspection, I noticed that there was something happening in this parafoveal area. And I'm like, what the heck is that? Let's get some angiography and see what is going on. And I was really impressed with these images. She's got all of these microaneurysm, kind of anomalous capillary network in that foveal area. And she really didn't have any other maculopathy or fundus abnormalities going on, but I thought this was super neat that you can actually see with this precision what's happening in this macular area. If you look at the deep plexus of her right eye, this abnormality goes down to the deep plexus. And her left eye looked similar, and in fact, probably even worse. You can see there's a lot of areas of capillary non-perfusion throughout which continues on through the deep plexus. And then I brought her back. I was curious what would happen if I brought her back a couple of months later. I wanted to look at a multi-scanner trend analysis, and nothing happened. So actually, I should take that back. This area looked pretty normal, but look at this. She is getting worse. She has a big patch of capillary non-perfusion here, and this is really over the course of about 2.5 months. So this technology continues to blow me away. It's showing me things that I certainly cannot just see on fundus exam, and the patient was actually able to really appreciate these images and understand when you say to them black is bad, they understand that something is not going right and they need to do a better job. And that's her other eye. Another diabetic here, you know, again, at first glance, it doesn't look too bad. She doesn't have a ton, this patient doesn't have a ton of retinopathy, but there is something going on right here if you look very closely. And what you'll appreciate here is brilliantly, this is neovascularization. You know, you move your, you can make a custom slab and move your line to the vitreoretinal interface, and you will pick up on these this neovascular frond. So maybe you weren't sure. I certainly wasn't, because there wasn't a whole lot of retinopathy going on. But this certainly said to me, yeah, she's got neovascularization there, and this prompted me to send her to the retina specialist. This is a newer patient that I just had that I was very excited about. So this is actually imaged on the Solix. This is the fundus photo was imaged on the Solix. And what I wanted to show you is that you can actually move your line. You can move the green line up and down, and your B scans will move with it. And you can see the angio right next to it. So not only can you manipulate the picture to look along the B scan, so you can specifically look at an abnormality, but you can also look at the angio at the same time. And we are the only people, or the only company, that can put all three of these technologies on the same platform. This is a patient that has diabetic macular edema. We can't even barely see the fovea vascular zone. There's lots of anomalous vasculature in here with areas of capillary non-perfusion. But the other eye is just amazing. Here's another image on the Solix. You can see there's an abnormal area here. And these photos can be made bigger, by the way. What I wanted to do is just show you everything on the same printout, but you can blow up this picture, you can increase contrast, you can take away exposure, you can do whatever you want to really make things pop. And here are these ridiculous, when I got this image, I sent it to all my buddies over at Visionix, and I said, I love this image. Fovea vascular zone is completely anomalous, and look at all of these beautiful neovascular fronds. Not so good for the patient, but certainly fun for us to look at. I'm going to switch over to AMD. I'm almost done, just a couple more cases. A 66-year-old Caucasian who had a history of AMD. She feels like things have gotten worse in this left eye. There is an anomalous lesion here in the macula. And look, just check it out. I mean, this is a 9x9 scan. It might even be a 12x12. I can't tell. I think it's a 12x12. It's incredible. Look at the resolution of that choroneovascular membrane. And this did not take any manipulation. This is just straight on imaging. This is a patient with geographic atrophy. This is a 9x9. And I think you can appreciate here that, again, the quality of these images, no manipulation necessary, patients looking straight ahead, is incredible. I mean, you can visualize all the way down here to the choroidal vasculature. You can even use this technology to monitor GA over time, which I'm starting to do just because the resolution is so excellent. And you can see the en face image right beside it. So one is structure, one is giving you function, and you're able to look at them side by side with excellent precision. I put the red square in there to highlight that if you were to use a good old-fashioned angio, you would capture probably, what does that come out to, about half of the lesion? You'd be missing this whole area of the lesion. So this new wide fields capability, or the wider fields of view of these images, really allows you to capture the entire image in one frame. Another patient, question, is it a CNV? Is it not a CNV? You can see that there is some bleeding there. There is an anomalous area in the macula. And again, check out the choroneovascular membrane. Now, this patient was not very cooperative, and I wanted to put it in here just to show you that even when you don't have a cooperative patient, even though you can see there are some saccades, there are some blinks, you can still capture brilliantly this choroidovascular membrane. And this is a massive one. So this one was a 6x6, and I believe I have her on a 9x9 too. There's the 9x9. So this, you can it just shows you in perspective how much area this choroidovascular membrane is taking up. And again, not a good patient, a lot of movement. The image was still able to capture. So a lot of times you have these difficult patients that can't fixate, perhaps because they have a CNV, and we just give up and we say, we're not even going to try to get an image. But guess what? You can get an image. This machine is able to get through so much mess because of the post-processing power and the projection artifact removal. And then glaucoma, just to sum this up, you know, these images were taken on the Solix. These are two optic nerve head photos taken on the Solix. When I looked at these, I thought that the left eye looked a little suspicious for glaucoma. There was definitely some asymmetry in the cupping. So I went ahead and ran a report. And here's my report on this patient. And I was shocked to see that essentially that left eye did not fall too much outside of where the right eye fell. Most of the parameters came out within our reference database. One thing I did notice is that the GCC, again, was falling in that orange zone in both eyes. So something to keep in mind, something to watch, something to see in a patient that does not have any other retinal disease. When the GCC is abnormal, we want to keep an eye on it, make sure it's not an early indicator of glaucoma. Again, we have our angio maps here, everything that you could possibly want on this page. This is another patient, very, very cupped in that right eye, somewhat cupped in the left eye. Is it glaucoma? Is it not glaucoma? And this kind of goes back to why that R&R, that better 0.7 micron resolution change is so important, because we want to be able to pick up on glaucoma as early as possible. So here's kind of a magnified report. I picked out pieces just to show you. We have our on-phos images on top. We have our RNFL images. And in this particular patient, there was asymmetry. That right eye that was much more cupped than the left is definitely showing some RNFL defect, which you can see here, which we're not seeing on the other eye. You have the vessel density map, that peripapillary or radial peripapillary capillary density map. So you have a way of looking everything side by side, and you have all of your metrics in the middle that we talked about before with the new RDB. So I think that is it. Let me see. Yes. I hope that I got through my excitement to all of you. I'm happy to share or answer any questions that anyone might have.
Excellent. Well, thank you so much, Julie. That was actually a really great tour. I think probably just about all of us out there haven't really had exposure to the technology yet. So thank you for giving us an introduction. By the way, if anyone wants to ask questions, click on the question box on the right side of the screen and feel free to ask, and we can try to answer a few of them here. So the first question, and Julie, I don't know if you're going to be prepared to answer this. What is the cost?
Well, it's a good thing I have people on here from the company to take that one. That's not for me to answer.
Right. So yeah, I don't know if anyone from the company wants to chime in with the approximate answer. Yes, no. Well, we'll move on to the next question. Maybe if somebody wants to jump in. Let's see.
From Visionix, if you want to book a virtual demo, we can go through the ROI calculator and show you kind of the features and then determine if it would fit with any of the clinics.
Okay, cool. Thanks, Rachel. So they do that online?
Yep, absolutely.
Excellent. So head on over to your website, I guess, and then just fill out the form, and that should do it. Cool. Okay. Question here, dilated or undilated pupils?
Every scan that you saw here was done through an undilated pupil. Believe it or not. No, actually, the choroidovascular membrane was not. That was done through a dilated pupil. You can do it through both. It's the same as with the Avanti, the same exact idea. You know, you can try to do an undilated. I have had a lot of success, or you can always dilate. Either way.
Right. Question here, and I guess this is more of a general question. Somebody has a different brand of OCT right now, thinking of upgrading and moving to Solix. So the question is, how do you compare images from an older OCT to this new unit?
Well, there's two parts to that. I mean, for retina, I would compare OCT-A to an MRI or a CT. Once you know how to interpret a scan, it really doesn't matter what technology you're on. Now, glaucoma is different. Glaucoma is going to depend on the platform that you're using because we all have different color-coded maps. We all have different metrics. So if you're familiar with one, you learn the other. I will add that Visionix has a platform called Visionix Academy, where there are tutorials on all different disease states and how to capture and interpret images. We also are going to have a platform where you are able to specifically ask me or another expert questions that may arise. So we have excellent customer support for the machine. I understand because when I first was starting to learn, I don't know what I would have done without my contacts over at the company. I was on the phone with them all the time. So I understand the importance of that. So yes, it's with the retina, same. You learn retina OCT, anterior segment OCT, it's easy. It's the glaucoma platform that is going to be different, and it's like learning to ride a bike. Once you learn it, you learn it.
Right. Question here, how fast is the image acquisition?
It takes about between 40 seconds and a minute in a cooperative patient. One of the differences between Solix and Avanti is that, for those of you that are familiar, Avanti would do two separate scans. We would get a horizontal, then it would stop, and then you would do a separate scan. The Solix goes straight through, which is actually an asset because the patient often, as you probably know, pulls back or stops participating if you allow them to, whereas this scan is a continuous flow, so the patient stays in the machine situated in the same location throughout the entire scan. I would say it won't take more than a minute.
Right. So we've had a couple questions here about anterior segment. I know you didn't get too far into it. Someone was actually asking about scleral lenses as well. Can you speak at all to sort of the anterior seg functionality?
I don't know if Peter, if you want to chime off on that. I mean, I know that this is being used for scleral lenses. I don't fit scleral lenses, so I don't want to answer incorrectly. But whatever the Avanti did, the Solix can do better because you have that full range AC. But if anyone from Visionix has something to add, please do.
I can help you with that. Are you talking size-wise or are you talking functionality? Size-wise, we're looking 18 by 6.25. Functionality, do you have specific questions?
Yeah, so the question here just, will it show the full coverage of a scleral lens?
Give me just 1 second.
I mean, because the full range.
Are you talking vault and landing zone? Yes, if 16 millimeters.
Got it. Okay. Question here, does the machine utilize eye tracking technology?
Yes.
Excellent. And, oh, interesting question. Can we use the device to screen for early keratoconus?
Well, I'll answer what I know about that, and then I'll let them chime in. But I know that you can use the epithelial thickness map to show you abnormal coloration or areas of redness where there's peaks or thick or thinning or thing like that on the cornea. But if you guys have anything else to add, that's the only way I know how.
Yes, using the epithelial thickness mapping. I agree.
And a question here, I think we've had a couple of questions sort of about the software. People are wondering sort of, can you distribute the data to different workstations? Do you have to be at physically the machine to work with the data, or can it transmit it to other machines around the office?
I'm going to send that to the software people over there. That I don't know.
Yes, it can transmit the data via the review stations software.
Great. And let's see.
Full functionality.
And billing and coding question here, if you guys are game to answer it.
Oh, goodness.
So I don't know, this one might be above all of our pay grade. So is it billable to CPT 92134 or 92133 only? Are there any additional CPT codes for the advanced angiolytic imaging?
No. There is no coding right now for analytics. I mean, for angio at all. You have to you have to code for regular OCT. That's going to be on any device, any angio that you buy. That is across the market. There is no OCT and geography codes.
Right.
That is correct, Dr. Rodman.
And let me see what other questions we have here. Oh, so this is actually a practical question. Will you be at Vision Expo East?
Oh my
Yes,
God.
we will. Absolutely.
Yep, and in fact, the Solix itself will be there as well, right? And I believe you are going to be at booth 2205, F2205. I know they've rearranged Expo East this year and renamed a bunch of the different areas, but it's going to be F2205, which is right at the front of the exhibit hall, if I understand correctly.
Yes, that is
Yes,
correct.
Yes, we will have multiple units there. We were going to have our first in-person preview of Solix. So please come by the booth, preview the product, get your live demonstration. We're going to have a special event on Friday evening, the first first exhibit. We have you there.
Great. And oh, I have one more question here. Hopefully you guys can answer this. When will the units actually be available for purchase? Are they shipping now, or is there a lead time?
They are available now.
Great. So I guess if someone wants a quote today, they can just hit up your website and get it that way. Or if they're coming out to Expo East, they can see you there.
Absolutely.
And if any of you have any practical questions from a clinical standpoint, doctor to doctor, that you don't want to ask on here, if you're shy or you think about it, please feel free to email me. Adam, I don't know if they have a way to share my email, but I'm always happy to answer any questions. Like I said, I've been using the technology. Nobody forced me to continue working on this device, and I chose to, and I love it. So just letting you guys know, if you have any questions, please reach out. I'm happy to answer the questions.
Excellent. And we'll actually have an archive of this webinar on ODwire with the discussion thread beneath it. So people can feel free to ask questions there and we can get a conversation going there. People might also be watching this at CEwire. We're going to be rebroadcasting this over and over again at CEwire this weekend. And I'm sure that's going to generate a bunch more questions as well. And I think that's about it for now. So thank you everyone for attending tonight. And, you know, I look forward to hopefully seeing a bunch of you at Expo East, getting out there again. But if not, you know, hopefully we can all get together online. So Julie, thank you so much for doing this again tonight.
Thanks, Adam. It was fun. Good luck,
All right.
everybody. Have a good night.
Yep. Good night, everyone.
Good night.